Hi, I'm Kara Patton. I'm a licensed clinical social worker and practicing clinician. I specialize in the treatment of trauma and assisting organizations aiming to integrate the information we'll discuss today into their services. Also pursuing a PhD in social work at the University of Utah as an interdisciplinary minority fellow with the American Psychological Association. Today we'll cover some of the information that is foundational for understanding trauma and how it relates to our work in various helping professions. Today we'll discuss key topics such as what is trauma, what are the effects and opportunities of trauma, what are the 6 key principles of trauma-informed care, and the 10 implementation domains of the trauma-informed approach. I always like to start with the definition of what trauma is. There are many that exist, and the way that we talk about it in our communities can be so different. I appreciate this one from SAMHSA as a way of establishing a common understanding as we move through the rest of the presentation. The trauma information from SAMHSA is readily available, continually developing, and open access. It's also widely used on a systems level, and we'll discuss that a little bit later. So, what is trauma? This definition states individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. What do you notice about this definition? What stands out to you? This definition includes what SAMHSA calls the 3 E's: the event, how it's experienced, and how it affects the person. What this definition helps us to understand is how we experience trauma is individual. What one person doesn't experience as traumatic, another may. That it may result from a single event or multiple events, or sets of circumstances, and that there are adverse effects which can impact functioning. Another very important point is that when we talk about trauma, we're really talking about the experience and the effect, not as much the event or events, but the outcomes for the person. When we start to think about it that way, we realize we're able to normalize some of the responses we might see. As we move forward and discuss symptoms associated with trauma, we can really understand how trauma responses are normal responses to abnormal events. Our systems doing the best they can to navigate trauma. When I teach in person, I'll ask what else people think could have been included. Some have said divorce, and on the flip side, some have said marriage. So it really is individual, but these experiences can be problematic for us. This is especially if they start earlier in life, or they're chronic, or experienced by the individual in an extreme way. As a clinician, I'm never sure about how someone might be affected by their experiences. That is really an opportunity for us to get curious. Sometimes something that I might consider benign is having a significant impact. And other times something that might affect me is less impactful for the person that I'm speaking with. A good general question is, how do you think this is affecting you? Because we know trauma can have lasting effects. Let's talk a little bit about how. Trauma can impair functioning in various realms. We can see impacts in occupational skills, mental health, social skills, emotional health, cognitive health, and physical health at a high level. So how do we know how trauma impacts us? At a foundational level, this is largely credited to the ACE study. This study was conducted in San Diego at Kaiser Permanente. There were 17,000 participants, which is a huge sample. People were asked about events they may have experienced before turning 18, and these experiences were strongly positively correlated with negative health outcomes. As exposure went up, so did risk for negative health outcomes. This is also a study that happened somewhat unexpectedly. Dr. Folletti was running a medical weight loss clinic, and people who had lost weight were coming back with the weight returned. Dr. Folletti started talking with people about their lives and recognized a devastating connection between their experiences and outcomes later in life. They found this dose effect. As scores on the questionnaire went up, so did those risks. Here are a few. These numbers are staggering. For people with 4 or more of those ACEs on the original questionnaire, the risk really starts to increase. It is important to note that it doesn't mean that a lower score doesn't matter or couldn't lead to some of these outcomes. This questionnaire is just measuring whether these 10 events happened or didn't. But when I first learned about these connections, I took notice. These outcomes are regulars on my caseload, as they are for many of us clinicians. The ACE study was conducted in San Diego, so let's take a look at what Utah numbers look like. On the left-hand side, in the green column, is the Utah-specific data from the Department of Health. In the orange column that says FEP receipt on the bottom, these are the people who were receiving public benefits from the Family Employment Program with the Department of Workforce Services, or what is commonly referred to as being within the welfare system. Let's just focus on those two columns for a moment. We'll come back to the other. The orange and green. When you look at those two, see what you notice. Again, the green is the general population and the orange is people receiving support. However, I think this data in the orange column can be generalized to many other agencies that are providing supports. When I look at this data, I see the left group, that 0 ACEs score, and the group all the way to the right in the 4 or more. Those are inversed. So 61% of the people surveyed who are receiving support are in that 4 or more category when we think about their scores on the ACEs questionnaire. When we start to think about how functioning can be impacted, it can paint a different picture about those who are coming to us for support. Much different than the myth of the welfare queen or other negative perceptions we often have about people receiving support. Now let's take a moment to talk about that darker line. I worked on the research team that collected the FEP data. We went around the state and asked people about their experiences with trauma. After those ACEs scores were shared with the Department of Workforce Services, they wanted us to train their staff about trauma. Even more, they said, let's invite everyone who wants to come, other agencies and community members. We did these trainings all around the state. And as researchers, my colleague, Dr. Mary Beth Vogel Ferguson, and I couldn't pass up another opportunity to collect more data. So as we taught, we included the actual ACEs questionnaire for those who attended. Across the state, we had about 3,000 attendees, a little bit more. Scores from various helping professions, healthcare, education, law enforcement, and criminal justice, pretty much every sector. Their scores are in the darker column. This is interesting because when we look at those scores, we see that the helping professions are right in between that general population and those who are coming to our agencies for support. So thinking back to that list of potentially traumatic events, this is how the original ACEs score broke down the events that they captured. If you'd like to see the original ACEs questionnaire, it's available open access. While foundational, the ACE study was conducted more than 20 years ago and has some limitations. For example, it was conducted in San Diego at Kaiser Permanente. We can consider that data might look a little bit different in other locations and with other populations. While that original sample highlights that trauma does not discriminate, what else might we be able to learn? Since the original study, there have been expanded versions exploring just that. First, we know that adversity exists beyond the original 10 questions on the original questionnaire. Also, we know about how trauma can affect us and how we might see these effects show up. That's really allowed us to expand our understanding. This is based off of a handout available on PACE's Connection, an amazing website that has a wealth of resources for people working to integrate this information into how they work. I strongly recommend checking it out, but it gives us a zoomed out perspective of the realms in which we might face adversity, not only within the household, but in the community, and increasingly so with environmental concerns. This new understanding has really allowed us to expand how we think about trauma. This pyramid comes from the CDC website. With ACEs, we were able to build the green sections of the pyramid. Since then, we've really been able to understand other aspects, things that we also need to consider: social and local contexts, as well as generational embodiments and historical trauma. So, what is historical trauma? And how has it earned its spot at the bottom of the ACEs pyramid? Dr. Maria Yellowhorse Braveheart is a key source for understanding the manifestation of historical trauma, particularly in Indigenous communities, but this understanding can really be expanded to others who've experienced this type of hardship. The study of historical trauma shows similar trauma responses to those we have discussed thus far. This deep grief for historical traumas has the capacity to impact people as if they had experienced these events firsthand themselves. This is an important consideration when working in more diverse communities. What happens in our communities matter. In Philadelphia, they replicated the ACE study in an urban environment with the addition of witnessing violence, experiencing discrimination, bullying, or displacement, and the results support that there is more to look at than those original 10 questions, more to consider. We can think about this in relation to where you live and practice. What salient issues exist for the people in your community? How might you seek to incorporate this knowledge into how you work? We understand that there is an intergenerational component to trauma. There is some debate in the field about whether this mechanism is on an epigenetic level, or where research is developing, or on the environmental level, or both. The old debate of nature versus nurture continues. Personally, I'm in the both camp, and I'll explore that a little bit more as we move forward. So the 4 key points to really consider as we move forward with the rest of the talk are that trauma responses are the brain in survival mode. We're going to continue to unpack this. Repeated trauma can make symptoms worse, and that people will behave in unexpected ways, but those ways may change over time as a response to trauma. I might see someone on Tuesday and they're doing great. Thursday comes around and I'm seeing a whole set of different symptoms associated with how I'm observing them. And then lastly, a trauma response is a normal response to abnormal events, and we'll continue to explore why that is the case. So we've covered what trauma is, what it can impact. Now I'd like to talk a little bit about the how. When we first experience something overwhelming, our bodies react. We might be aware of some of these responses in the moment, and we might not. There might be other responses that we notice, but it's important to note that our physical body has responses to emotional events. Socially, we separate mental and physical health, but our bodies don't do that. As providers, we can see those links, that mind-body connection. So let's take a look at why our bodies are responding in that way. When we look at the triune brain as defined by MacLean, we can get some insight. I like to think of this as a channel running from the reptilian complex up to the neocortex. The reptilian complex at the base of our skull is our instinctual or animal brain, or our lizard brain. This part of our brain is always running, and it's meant to keep us safe. It's constantly taking in information. If everything is good, it sends that information up to the limbic system. The limbic system is largely responsible for our emotions. It also houses our fight, flight, and freeze responses, but we're going to come back to that in just a moment. If everything is good, from the reptilian complex, information passes through to the limbic system and into the prefrontal cortex. This is where executive functioning lives. Things like problem solving, multitasking, negotiation, abstract thought, all up here. If everything is not good and the reptilian complex picks up on that, we have a different process take place. It will send up a message to the limbic system that says that we need to protect ourselves. The limbic system ceases to be a pass-through to the neocortex and switches into fight, flight, or freeze. Bessel van der Kolk, a leading researcher in the trauma field, calls this the smoke alarm. You see, the limbic system is not particularly good at multitasking. That really belongs to the neocortex. So it's either on or off. It's either or. It's really pretty smart. This process is meant to preserve life if we come across danger. There are not many bears who will sit down and negotiate with us, so it makes sense that our brains use that energy to fight, flight, or freeze rather than utilize executive functioning. We need that energy to keep us safe, so this process makes a lot of sense. It is that process that we're looking at in this image. On the left, there's a healthy baby brain. On the right, the baby has experienced some form of abuse. The story behind this image is that the baby on the right was taken out of an orphanage where children were being neglected, and that when you walked into this nursery, it was completely silent. What do you normally hear when you walk into a nursery? Well, it's not often silence. So for both brains, at the bottom of the slide is where we would see that reptilian complex. For the healthy baby brain, maybe there's a little activity in that section, but we still see some movement up that channel into the neocortex at the top. On this image, black is the least active and red is the most active. For the baby who has experienced abuse, we see a lot of activity in the base of the brain, and this activity or stress is hijacking that channel from progressing up to the neocortex. This baby is in survival mode. So thinking about this and what we've discussed thus far, what happens if this baby in survival mode stays in this chronic state of stress and turns 5 or 10 or 25? How might that change how we see this person? Those parts of the brain are not gone, but if we're constantly using our survival mode, that is what grows stronger. What skills or behaviors might we see in someone who has had chronic exposure and less opportunity to develop those skills in the neocortex? They may be really good at surviving and need some support with other things that they could depend on executive functioning for, had that opportunity to develop the way this healthy baby brain would if things stayed the same. We need this survival response. It keeps us safe. It's just not meant to be how we live our lives. It's kind of like driving your car everywhere you go 100 miles per hour. It's capable of getting up there in speeds, but eventually it will break down or crash. This is one of those links between negative health outcomes and trauma responses. On a behavioral level, we might see some of these things. On the historical trauma response slide earlier, we saw a quote from Braveheart about trying to medicate trauma responses. As researchers, one of our favorite questions is, how come? If we think about what we know about how the brain's functioning, and not having access to the part of the brain responsible for problem solving or some of our more rational thought, we can understand that some of the behaviors that we might observe don't make sense. They're not coming from that part of the brain though. They're coming from that smoke alarm. But they're often attempts to regulate our systems and get us out of that survival mode and back into homeostasis. This is a tool I will often use with people I work with to help them understand how some of their behaviors might be associated with trauma. It's called the window of tolerance. It's available online, open access. It's the same information we have covered in talking about the brain in a different format. In the middle, we have the comfort zone. This is when all of the channels are open and we have access to that executive functioning. The green box on the left-hand side shows that reptilian complex picking up something and dysregulation occurring. We're either kicking up into hyperarousal or down into hypoarousal. We might vacillate between the two or see some behaviors outside of this. But what we're really trying to do in these behaviors is the how come piece that I was talking about. It's our attempt to return to that homeostasis or that comfort zone. Luckily, we can use skills to replace some of these behaviors, but we might have to work on building that muscle. However, it is possible, and it's also where we can come in and be of service as clinicians and providers. It's important to remember that possibility. People are capable of amazing things, and trauma in itself is not a diagnosis. The ACE questionnaire is not a clinical tool because we can see so much variability on the individual level. Part of this variability comes down to resilience. This is the other side of the coin when we think about trauma. Resilience is an amazing thing, particularly because it's something that can be built across the lifespan. We largely learn how to be resilient from others. We might have varying levels of resilience inherently, but we can strengthen it. This is where understanding how to do that is so valuable from those of us in helping professions. This is our opportunity to help cultivate change in the people that we work with. Part of being able to tip the scales is being able to recognize what is going on in others and also in ourselves. What have you noticed in others that you work with? If we work in the community or in clinical practice, or even in our own lives and families, are there ways we're working to build health? If we're doing treatment, are we doing treatment planning that might be able to incorporate resilience into that plan? Are there other opportunities that we can take advantage of to use this information? And do we do so in a way that fosters key components of resilience? Are we collaborative and trustworthy? Are we safe and empowering? How can we build that into our practice? We know that having positive experiences can serve to buffer the negative effects of trauma, particularly for children as they work to form their perceptions of the world. We don't get to erase the trauma that people have experienced in the helping professions, but we can work to change their relationship to it. These positive experiences can be small at times, but still have a huge impact. These are building blocks for a healthy life. Also important to consider the social aspects and how the community or environment can provide community resilience to those who are a part of it. How can we build and foster healthy communities? If we're working with diverse populations, it's imperative to consider what resilience means and looks like to them. There may be very meaningful and resilience-building practices that are left out of the common literature. It's another opportunity to think about how we can make meaningful repairs to those people in our communities. Earlier, when I showed the slide with the PhET and Utah data, there was the last column representing those of us in the helping profession. This information is relevant to providers too. For example, you may go out of your window of tolerance when things get really stressful, or can remember a time when you have. As a reminder, our ACEs scores were higher than the general population, but lower than those seeking services. It's important to remember that we are people too. Trauma and resilience building is not just for the people that we serve, but a really important part of our jobs as well. These are terms that sometimes we'll hear interchangeably. People will say, "I'm super burned out." I see a number of healthcare providers in my practice as clients, and it's valuable to understand that what we might experience as providers is important to consider too. This information comes from the National Child Traumatic Stress Network, and there are a number of resources about trauma and resources for providers specifically available. It is important to note that if we're not actively building health for ourselves, we risk being impacted negatively too, or that our work may be impacted. I think of secondary trauma the same way that we think about secondhand smoke now. Here are some of the risk factors for secondary trauma: having personal trauma, being isolated, being overworked, having high caseloads. Considering that we have the scores of helpers in Utah, we know that there's trauma in our field. And if some of these conditions didn't exist pre-pandemic, there's a pretty good chance they do now. So it's paramount that we take care of ourselves too. We can't give what we don't have, so we have to fill up our wells. It is also an act of service to others to be sure that we're cared for well. Because this field is so rewarding. We also stand to gain benefits from this meaningful work in a way that is unique to helping professions. So now we're going to talk about what we can do with this information. Coming back to the information from SAMHSA, there's this really important concept, and it is SAMHSA's concept of a trauma-informed approach. It's different than trauma-informed care necessarily, but thinking about how we can generalize it to all of the communities that we know can really benefit from this information. So SAMHSA loves to have some of these mnemonic devices. We talked about the 3 E's in the definition. Now we're going to talk about the 4 R's. These 4 R's help us remember what the trauma-informed approach is. It is when we realize the widespread impact of trauma and understand potential paths for recovery and prevention. When we respond by fully integrating knowledge about trauma into policies, procedures, and practices. When we recognize the signs and symptoms of trauma in our clients, families, staff, and others involved within our systems of helping. And when we actively work to resist re-traumatization for those that we serve. And an important way for us to do that is by integrating the 6 key principles of trauma-informed approach. Those are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and that we're considering cultural, historical, and gender issues. So I like these 6 key principles a lot, and the way that I think about them is that these are often things that we may lose or be prevented from experiencing in our lives when we experience trauma. So for those of us in the helping profession, we can help repair that experience of loss. If I'm working with someone, how can I help them to cultivate safety, either to reestablish or establish for the first time a sense of empowerment, voice, and choice? What can I do to help bolster or support the development of these 6 key principles in someone's life? So how we integrate these 6 key principles of the trauma-informed approach is really important when we think about how we deliver services on an organizational or systems level. That's where these 10 implementation domains of the trauma-informed approach come in. These are really talking about the most important components of an organization, how we deliver services, how we interact with the communities that we serve. These 10 implementation domains are cross-sector collaboration, governance and leadership, progress monitoring and quality assurance, evaluation, engagement and involvement, screening assessment and treatment delivery, financing, training and workforce development, policy, and lastly, but not least, considering the physical environment. So really the way that we use our understanding of these 10 implementation domains is by thinking about a crosswalk between the 6 key principles of the trauma-informed approach and the 10 implementation domains. So really kind of thinking about this in terms of a logic model. When I think about progress monitoring and quality assurance, am I evaluating or considering if people experience safety in that process? If I'm thinking about evaluation, how do I do that in a collaborative way? Do I have peer support integrated into my treatment delivery? Am I considering cultural, historical, and gender issues in my training and workforce development, for example? So if I were to look at any one of those 10 implementation domains, I would really like to be able to evaluate how I integrate those 6 key principles into how I'm doing the work that I'm doing. It's a great strategy for evaluating our progress in working towards the trauma-informed approach and working to really reflect the information that we're talking about today, and also those 4 R's of being able to resist re-traumatizing the people that we work with in the systems that we work within. When we think about integrating the trauma-informed approach, considerations for a system or organization who are working to implement this information are, why is this valuable? Why do we care about integrating trauma information into how we work? Why do we want to integrate the trauma-informed approach? How will implementing this approach benefit the organization? Both stakeholders, patients, people that we serve, also the people who work within the organization itself. What challenges might we face in implementation? What barriers do we foresee presenting themselves? Because that will allow us to consider how we might be able to overcome those challenges. But lastly, this isn't a checkbox. This isn't something that we can integrate and finish. Working in a way that reflects the trauma-informed approach is a way of being. It's continual. Just as the loop of the 10 implementation domains was not linear, neither is working in a trauma-informed way. We're continually striving to integrate new information and improve our processes. It is a practice, just as so many other things are within our field. So, some high-level strategies for integrating the trauma-informed approach. Big goals are really achievable if we can break them down into smaller, achievable milestones. These are 16 strategies that come from SAMHSA. They have an amazing treatment improvement protocol that's available, open access, called Tip 57, and it's specifically about integrating the trauma-informed approach. It names these 16 high-level strategies to be implemented cross-sector in almost any setting. What I like about this information is that it's not overly prescriptive, isn't telling us exactly how we have to do it, and that allows us to really tailor the information and the strategies for our own needs and the needs of the people that we work with. Thinking about, how do we develop an implementation plan? How might we show our organizational commitment to trauma-informed approaches? Is it through a mission statement or vision statement? How we evaluate our processes? Have we any opportunity to change the actual physical environment to be more trauma-informed? Thinking about ways that we can build this supportive organization benefits not only those working within the organization, but also those who serve. It's an important consideration in the trauma-informed approach that we consider both the helper and those being helped. It's a high-level kind of overview of the trauma-informed approach, what trauma is, how we might see it impact us and those that we serve, and also thinking about how we apply this information to ourselves as people. there's so much information to consider and think about as we move forward in this work. But this was just an introduction to what that information looks like and the foundations of building a trauma-informed approach and how we work. Thank you for spending some time with me today, and I look forward to hearing about your trauma-informed work in the field as you move forward.